Welcome to the Gas Permeable Lens Institute Keratoconus Fitting Module. I am Dr. Christine Sint, Associate Professor of Clinical Ophthalmology and Director of the Contact Lens Clinic at the University of Iowa. Contact lenses are an excellent way to optically correct an irregular cornea. Keratoconus is a common condition where GP lenses are the treatment of choice. Understanding the principles of fitting keratoconus leads to decreased chair time and increased patient satisfaction. There are several options for contact lenses for fitting keratoconus. Today, we will limit our discussion to corneal GP lenses. The CLEX study showed that apical bearing leads to increased incident scarring. Vortex epithelial staining is an indication of harsh apical bearing. You want to adjust the lens curves such that the best possible alignment is achieved over the whole lens. Spreading the pressure of the contact lens across the entire corneal surface will increase comfort and wearing time. Most keratoconus patients wear their contact lenses all waking hours. Low oxygen transmission lenses should be avoided, since this has been shown to cause endothelial stress. There are a few fitting philosophies, but the most common and the most widely accepted is the philosophy of three-point touch. The goal of three-point touch is to achieve a mild or feather touch over the apex of the cone. There should also be at least two other areas of touch in the corneal mid-periphery. This gives a bullseye appearance on the fluorescein pattern. There are four zones created with three-point touch method. First, slight apical touch. Second, paracentral clearing. Third, mid-peripheral bearing. And fourth, peripheral clearance. In this design, the weight of the lens is distributed across the cornea and not focused on one specific area. It is thought that mild apical bearing will provide some amount of regularity to the anterior corneal surface and possibly improve visual acuity in comparison with apical clearance methods. It is important to monitor these patients to ensure that apical bearing does not become excessive, possibly resulting in corneal complications. Large diameter lenses will force centration of the lens and allow pupil coverage. A large diameter lens will also allow for larger optic zone, which may help with flare. These lenses are indicated for broad or inferior cones. Since lid attachment can be achieved, they will often stay in the eye when smaller lenses will not. Although large lenses are frequently more comfortable, the peripheral lens-to-cornea relationship can be more difficult to align, often causing irritation to the lower eyelid. In traditional keratoconus designs, the optic zone decreases as the base curve steepens. The secondary curve is significantly flatter than the base curve. Typically, multiple peripheral curves are needed to correspond to the rapidly flattening mid-peripheral and peripheral cornea. The peripheral curves are generally flatter and wider than conventional lenses to provide greater edge clearance and prevent peripheral seal-off or lens-to-cornea adherence. I think of these designs like fitting a hat over your head and shoulders. You want the hat, the base curve and optic zone, to be the right size and depth to fit over the head without bearing, while the brim, the peripheral curves in diameter, should land gently on the shoulders, distributing the weight evenly. A traditional keratoconus design will always center over the highest elevation. A flat lens will rock and teeter on the cone, while a steep lens will cause peripheral impingement. The CLEX study coined the term fodocle, or first definite apical clearance lens. The fodocle is the flattest lens to vault the apex of the cone. By using a standardized fitting set, the contact lens evaluates the sagittal depth of the cornea, rather than the apical curve radius. The fodocle is the best way to measure change on the cornea, since topographical maps can be exceedingly variable. Reverse geometry lenses are gaining in popularity as our understanding of sagittal depth grows. The term reverse geometry refers to a secondary curve which is steeper than the base curve. The secondary curve, rather than the base curve, is used to raise or lower the sagittal depth of the lens. Like the brim of a hat, the secondary curve determines the centration of the lens. A large lens and steeper secondary curve position the lens centrally, allowing the base curve to vault the cornea. These lenses exhibit greater than average edge lift to ensure tear exchange and prevent peripheral seal-off. While the large optic zone and excellent centration are an advantage of this design, they tend to have more lower lid interaction secondary to the large diameter and the increased edge lift. In some patients, this may cause increased lens awareness. The ideal reverse geometry lens should be positioned centrally with central fluorescein pooling. For inferior cones or pellucid marginal degeneration patients, there may be an inferior area of gracing touch. The lens should have fairly wide band of fluorescein at the edge. Sagittal depth is the most important concept in understanding how to fit keratoconus. Sagittal depth is the distance under the curve to a defined point. In this example, the sagittal depth is measured from the cornea to the iris plane. While these two corneas have equal corneal curvatures, they have very different sagittal depths. All contact lenses are fit by sagittal depth to create the optimal lens-cornea relationship. This understanding becomes more important as various parameters are modified, such as base curve, peripheral curves, and diameter. The apical curve radius, eccentricity of the peripheral cornea, and corneal diameter of the eye, and similarly, the base curve radius, the peripheral curves of the lens, and the diameter of the lens interact to form the overall sagittal height of the cornea and contact lens. As the apical curve radius or base curve increases, so does the sagittal depth. Similarly, if the peripheral curve steepens, so does the sagittal depth. Alternately, if none of the curves are changed and the lens is made larger, the sagittal depth also increases. What this means is if the corneal readings are flat, but the overall diameter of the cornea is large, the eye will require a lens with greater sagittal depth. Things that increase the sagittal depth of the contact lens include steepening the base curve, steepening the peripheral curves, or increasing the diameter of the lens or optic zone. Things which decrease the sagittal depth include flattening the base curve, flattening the peripheral curves, or decreasing the diameter of the lens or optic zone. If there is too much sagittal depth, there will be a vaulting of the cone when the lens is centered over the apical curve. Lenses with high sagittal depth will often exhibit bubbles in the pooling area and ride low over the cone. Lenses which have too little sagittal depth will show central touch when centered over the cone. These lenses will often slide off the corneal apex as the lens interacts with the lids. Low sagittal depth lenses will often ride high or decenter laterally. Bubbles may come in from the edge of the lens. So, what should you consider when choosing a lens design? The lens should be relatively easy to fit, with simple modification of lens parameters. It is helpful to have a fitting set with common modifications included, such as a larger or smaller diameter and steeper or flatter peripheral curves. Being able to assess parameter changes from a fitting set will minimize fitting time and increased first fit success. A lens design should have minimal apical bearing and spread the lens pressure across the cornea for minimal corneal insult and increased patient comfort. And finally, you should be able to get repeatable replacements, which reduces chair time and increases profits. There are many options available today. These lenses vary by optic zone, peripheral geometry, and diameter. Each lens will have its own subtle fitting technique, as well as how and what parameters are able to be modified. These photos demonstrate how dramatically a lens design will vary the fitting relationship for a given base curve. It is recommended to pick a design and work with it enough to understand its unique fitting relationships. But why do we need more than one lens design? Because there are many types of cones. Nipple cones are small, paracentral cones, usually less than 5 millimeters in diameter. Although the cone diameter is very small, these cones frequently have the steepest apical curves. Nipple cones are located within the pupil margins and can be visually devastating. When evaluating the cone type, not only should the axial map be evaluated, but also the anterior elevation map and the slit lamp view. The axial map will give the apical curve radius, but the elevation map and the slit lamp view will show the location of the cone. Keep in mind the elevation map will show the highest point on the cornea, and the contact lens will always want to center on the highest point, or slide off the highest point, depending on the sagittal depth of the lens. In this case, the axial map shows a centrally located cone. Note on the elevation map, the cone apex is located within the pupil margin. This cone, or thinning area, is also seen on the slit lamp cross-section. Small, centrally located cones are relatively easy to fit, with traditional cone designs working well. Fortunately, there are many design options for this type of cone. Oval cones are inferior and broader based compared to nipple cones. The thinning is often noted over a larger area of the cornea. On the axial map, the oval cone will appear to encompass the majority of the inferior cornea. The elevation map will show a broader area of elevation. The slit lamp view is vital for determining the affected area. Note on this slit lamp view, the thinning is evident across nearly the entire half of the inferior cornea. Axial maps may misidentify nipple cones as oval cones. This happens because the axial map is not good at identifying local areas of change. In this case, the axial map shows a broad area of change, while both the elevation map and the slit lamp view show a small central nipple cone. Of note in this case is the significant posterior bowing of the cornea. This posterior irregularity may limit potential vision. While the cone is generally located inferiorly, the corneal apex may be found in almost any quadrant. In this case, the axial map shows a broad area of change in the inferior temporal quadrant of each eye. The anterior and posterior elevation maps, as well as the pachymetry map, isolates the cone apex in its temporal location. This is important because the contact lens will always want to center over the cone. Note in this case how well the fluorescein pattern correlates to the elevation map. Large diameter or reverse geometry lenses force centration if pupil coverage is a problem. Pellucid marginal degeneration is often mistaken for keratoconus. Although the two entities are both corneal ectasias, the thinning in pellucid marginal degeneration is 1 to 2 millimeters from the limbal margin. This results in high, regular corneal astigmatism, which may be corrected by glasses or soft toric contact lenses for many years. When GP lenses are needed, pellucid marginal degeneration is one of the most difficult and frustrating irregular corneas to fit. In true pellucid marginal degeneration, the axial map will show a kissing dove pattern indicating high astigmatism. The slit lamp view will show thinning at the limbal margin, while the elevation map will show the highest point well away from the corneal center. Not all kissing doves, however, are pellucid marginal degeneration. In this case, the slit lamp view and elevation map both show an oval cone just below the pupil margin. Reverse geometry lenses or scleral lenses are frequently the lens of choice for pellucid marginal degeneration. Since the pathology is near the limbus, small lenses will ride low with poor pupil coverage. Often there is inferior liftoff. Traditional keratoconus lenses do not fit pellucid marginal degeneration eyes. This is probably the single biggest mistake I see in my referral population, frustrating both the patient and the referring practitioner. Since the pathology is at the limbal margin, the contact lens is pushed upward, causing bearing over the peripheral curves and vaulting of the optical center. Globus cones are the largest area of ectasia, involving 75 to 90% of the cornea. Although exceedingly rare, globus cones are easy to fit, rarely needing any special design on the GP lens. When fitting the GP lens, the diameter should be selected first. The optimal diameter will allow for lid attachment, be clear of the lower lids, and locate centrally to allow for adequate pupil coverage. Since the contact lens will fit over the highest elevation, small diameter lenses fit well on centrally located cones. In most centrally located cones, the lens will pick up with the blink and either stay lid attached or locate centrally, staying away from the lower lid. For small central cones, traditional cone designs work well. As the cone becomes steeper, the base curve is steepened while the optic zone is reduced, effectively keeping the same sagittal depth. Generally, this cone type uses smaller diameter lenses, but if a larger lens is desired for comfort purposes, a smaller optic zone may be ordered. Inferior cones will cause the lens to ride low. In these cases, a small diameter is a poor choice since the lens will not properly cover the pupil. Large diameter lenses force centration and are often a good starting place for inferior broad cones. Standard intralimbal designs are good for early emerging cones, while large diameter traditional cone designs may be better for moderate oval cones. Large diameter lenses generally have larger optic zones, as seen with this scleral lens in the right-hand photo. In this patient with an inferior cone, a small flat lens rides high, with the inferior edge bearing over the cone, while a large, relatively steeper lens has better centration. The best options for inferior cones include small and flat, or low sagittal depth, lenses, which will tend to ride high. However, this lens may have inferior liftoff and the lens may rock on the cone. Large diameter lenses force centration, which will give better pupil coverage. However, larger lenses have more peripheral curves to align with the cornea, and the peripheral geometry of the lens tends to become more of a concern, causing more lower lid interaction. Reverse geometry lenses are a good option if standard large geometry lenses cause too much apical bearing, peripheral seal-off, or better centration is still required. Changing diameter changes sagittal depth. In this patient, notice how simply increasing the diameter increases the central pooling, or sagittal depth. The base curve should be flattened 0.25 diopters for every half millimeter in. Changing diameter changes sagittal depth. In this patient, notice how simply increasing the diameter increases the central pooling, or sagittal depth. Lid location affects the diameter choice. In this patient with a ptosis, the lens rode low secondary to lid downward forces. A large diameter lens was ultimately used to force adequate pupil coverage. After ptosis surgery, she returned to her original diameter. The base curve is located within the optical zone of the contact lens. The base curve exerts the greatest effect on sagittal depth. There are many opinions on how to choose an initial base curve to put on the eye. The 3 to 4 millimeter rule states to go into the temporal quadrant out 3 to 4 millimeters and choose the base curve associated with the K reading at that point. The yellow rule says to pick the curve corresponding to the yellow area on the map.
In the 0.2 millimeter flatter than average K rule, convert dioptric measurements to millimeters of curvature. Select the initial base curve, which is 0.2 millimeters flatter than the topography average. Some practitioners advocate fitting the reference sphere, otherwise known as the best fit sphere. Some methods even suggest fitting the steepest K reading. So what works? Well, that depends on the type of cone and the lens design. Generally, it is best to use the fitting set recommendation, but in the absence of a fitting guide, any of these methods work moderately well. The most important thing is just to get a lens on the eye and evaluate the fit pattern. The contact lens is your best topographer, and the first lens is unlikely to be the final selection. Remind your patient that you are putting the first lens on the eye to get yourself orientated, and that the patient won't be able to see and the lens will likely be uncomfortable. The base curve should be evaluated with the lens centered over the cone. If three-point touch method is employed, optimal sagittal depth occurs when there is gracing touch over the cone. Once the right cone to cornea touch is achieved, changes to the parameters must be balanced to keep the same sagittal depth under the lens. Remember, flat lenses, low sagittal depth, ride high. Steep lenses, high sagittal depth, ride low. As seen on this patient, a flat lens will decenter. Note that a decentered lens may give the false impression of a steep fit, since the center of the contact lens is located over the peripheral cornea. The ideal base curve relationship will show gracing touch over the cone. As the lens becomes too steep, the lens drops and does not pick up with the blink. In this case, there is vaulting over the cone, indicating too much sagittal depth. Pooling at the base of the cone is an indication that there is too much sagittal depth. Sagittal depth can be lowered by flattening the base curve, decreasing the overall or optic zone diameters, or flattening the peripheral curves. If the sagittal depth of the lens is too high, as seen in this video with fluorescein clearance over the cone, bubbles may form in the optical zone. Reduction of the sagittal depth may be accomplished by flattening the base curve, flattening the peripheral curves, or decreasing the diameter or optic zone size. However, bubbles may form under the lens in the presence of lower sagittal depth. In this case, there is gracing touch over the cone with significant pooling around the base to the edge of the lens. Major changes in sagittal depth are not necessary, so a new lens with a larger optic zone and steeper peripheral curves should be ordered, which results in a more aligned fit without central bubbles. Note that the slight increase in sagittal depth causes the lens to drop more quickly. Keratoconus eyes often require peripheral curve changes to align with a rapidly changing peripheral corneal geometry. In these lenses with the same base curve and diameter, only the peripheral curves have been altered. Although it is difficult to tell if sagittal depth over the apical cone has changed, there are subtle changes in the lid interactions and movement of the lens. Note that the slightly lower sagittal depth and increased lid interactions of the flatter periphery causes the lens to pick up and hang with the lid longer, while the steeper periphery falls to the lower lid faster. Edge lift affects patient comfort. Too much edge lift will increase lens awareness, while too little edge lift will contribute to the lens adherence. The ideal edge lift is a fluorescein bandwidth of 0.6 to 0.8 millimeters wide. A common temptation is to adjust the peripheral curve by adjusting the base curve. If good central alignment is achieved and there is peripheral liftoff, the peripheral curves should be steepened. As seen in this video, altering the base curve will not affect the peripheral curve alignment, but will adversely affect the sagittal depth of the lens. If there is peripheral seal-off of the lens, a flatter periphery is needed. In large diameter designs, it can be more difficult to align the peripheral cornea. If spherical, non-keratoconus, designs are used on a keratoconus eye, the periphery will generally need to be loosened. To loosen the fit, the peripheral curves can be made flatter and wider. the base curve can be flattened or the optic zone can be reduced. In these photos, the lens on the left is suffering from lens adherence, but clearly the low sagittal depth is already causing touch over the cone. The far periphery shows minimal edge lift. Flattening the base curve would not be a good choice here because that would cause further reduction in sagittal depth. In this case, the best option would be to steepen the base curve, shrink the optic zone, while simultaneously flattening and widening the peripheral curves. The right lens shows significant vault over the cone. While there is mid-peripheral bearing, there is adequate edge lift. In this case, the base curve should be flattened before the judgment on periphery can be made. It is commonly thought that a periphery is either too flat or too steep, when, in reality, the periphery is correct, but the overall sagittal depth of the contact lens is wrong. In this case, the upper eyelid is causing this flat lens to bear on the superior slope of the cone. This rocking on the cone is inducing inferior liftoff of the lens. The periphery of the lens should only be assessed once proper sagittal depth of the contact lens has been determined. In this case, where there is slightly low sagittal depth causing rocking of the contact lens, increasing the optic zone and steepening the peripheral curves eliminates the problem. Another option would be to steepen the base curve and decrease the diameter. This too would slightly increase the vault, while the smaller diameter would require narrowing of the peripheral curve widths, effectively tightening the periphery. Quadrant-specific or rotationally asymmetric contact lenses are available when there is inferior liftoff. In this design, just the inferior peripheral curves are steepened, designed to tuck in the lens under the cone. This design is extremely helpful for pellucid marginal degeneration. However, it should be used with caution in keratoconus, as most problems with inferior lift can be managed with sagittal depth alterations through diameter, base curve, and edge lift changes. When all else fails, piggybacking is not a bad option. Piggybacking protects the cornea from lens sensations, drying, and bearing. Piggybacking will not help comfort if the lid is the major cause of the irritation. High decay lenses are recommended to avoid endothelial stress. However, in very steep corneas, the extremely low modulus of a daily disposable lens may be preferred for better drapage without gaps. The GP lens should move independently of the soft lens. If the lens is riding high, try reducing the diameter to have less lid interaction, steepening the base curve to increase the sagittal depth, or reducing the edge lift to reduce lid interaction and give a slightly increased sag. If the lens is riding low, try increasing the diameter to force centration, flattening the base curve to reduce sagittal depth, or increasing the edge lift to have more lid interaction. Remember, flat lenses ride high, steep lenses ride low. So now let's put it all together and look at this case example. This is a 25-year-old Hispanic female presenting for the first contact lens fit. She has a small, moderate, centrally located cone. Remember to look at the elevation map for the location of the cone. Also, the slit lamp view will give you the location. Based on her mid-K range, a 7.03 mm or 48 diopter contact lens was placed on her eye. Due to the central location of her cone, a standard 8.7 mm diameter lens and a standard periphery were used. The lens showed inferior liftoff during the blink. Although the lens would pick up with the lid, it would subsequently fall to the lower eyelid. When centered on the cone, the lens showed minimal apical touch with significant pooling around the base of the cone. In this case, there is slightly too much sagittal depth. The option to reduce sagittal depth includes decreasing the diameter or optic zone size, flattening the base curve, or flattening the peripheral curves. By decreasing the lens diameter, the lens no longer has inferior liftoff. The reduction in peripheral curve width has caused a relatively tight-looking periphery. However, the periphery should not be judged until the correct sagittal depth is achieved. Assessing the vault over the cone, this lens has slightly too much sagittal depth. Steep lenses will ride low. If only the base curve is flattened compared to the original fit, the lens rides high with the lid and decenters. But there is appropriate three-point touch over the cone when aligned. Since there is appropriate three-point touch over the cone when aligned, a smaller lens with the flatter base curve would be appropriate. If the lens diameter decreases and the base curve is flattened, the lens centers with optimal three-point touch. Because the overall sagittal depth has decreased significantly, there is now moderate to excessive edge clearance. This base curve and diameter should be ordered with a steep periphery. The smaller diameter, along with the flatter base curve and steeper peripheral curves, produces the ideal fit. To review the fitting algorithm, first, determine the diameter necessary for best centration. Second, determine the base curve necessary for best cone alignment for the appropriate diameter. Third, assess the peripheral curves. Once the final fit is determined, the power should be assessed. Retinoscopy is a powerful tool when refracting keratocones. Not only will retinoscopy speed up the exam, it will determine residual astigmatism and optical opacities. During the subjective refraction, large steps should be initially taken. The final lens power will equal the trial contact lens plus the over-refraction. Make sure you vertex anything over 4 diopters. The refraction should be finished with the room lights on, as this will control the pupil size. Since keratoconic lenses may be fit relatively small, proper lighting is important for optimal vision. Reassure the patient, however, if vision is not optimal at the fitting visit. Vision often improves over the first few weeks of lens wear as the patient adapts to the lenses. In some cases, though, the vision may continue to have ghosting or halos. This could be a function of the pupil size, cone location, or severity. Posterior bowing of the cornea will affect final visual outcome. Inform the patient that while good vision can be achieved most of the time, there may be circumstances, like night driving, where the vision decreases secondary to the pupil size. A lens which slides or is tipped or tilted on the cornea can induce significant amounts of unwanted astigmatism. A tilted lens can cause distortion and fluctuating vision. A steeper secondary curve, such as on a reverse geometry lens, can help prevent lens tilt by centering the lens horizontally and vertically on the eye. If residual astigmatism remains, there are several options. The easiest is overcorrective glasses. If overcorrective glasses are prescribed, an anti-reflective coating or photochromatic lens should be recommended to help with glare. Front surface toric lenses are exceedingly difficult to fit on a cone. However, if this is desired, be sure to increase the overall diameter and incorporate prism ballasting into the design. As the base curve steepens, the prism ballast has less effect and will often get nasal rotation. Therefore, steeper lenses need more prism. In summary, first, determine the location of the cone. Elevation maps and slit lamp examinations are helpful. The lens will center over the high area. Choose a design and diameter of the lens based on the cone type. Large lenses force centration, while small lenses will center on the cone. Patients with pellucid marginal degeneration require larger diameter lenses or even scleral contact lenses. Select the base curve based on the fitting algorithm of your choice. Place the lens on the eye and determine the sagittal depth. Flat lenses will ride high and steep lenses will ride low. Only evaluate the overall sagittal depth with the lens centered on the cone. To decrease the sagittal depth, you need to decrease the diameter or optic zone, flatten the base curve, or widen and flatten the peripheral curves. To increase the sagittal depth, increase the overall diameter or optic zone diameter, steepen the base curve, or narrow or steepen the peripheral curves. The diameter of the contact lens should be chosen first. Choose a size that optimizes centration and minimizes lid interaction. A large diameter lens will increase the sagittal depth, while a small diameter lens will decrease the sagittal depth. Next, choose the base curve. The base curve has the greatest effect on sagittal depth. Do not adjust the base curve to adjust peripheral curves. When the lens is centered on the eye, you should see gracing touch over the cone. The peripheral curves and edgeless system affects comfort. Determine the appropriate peripheral curves after the diameter and base curve have been selected. Alter diameter and base curve before ordering quadrant-specific designs. Most importantly, don't make all the changes at once. Large fitting steps are helpful. Practice altering one parameter at a time to learn how each change impacts the overall fit. Remember, these are general principles, and each lens will have its own specific nuances. Thank you for watching the GPLI Keratoconus fitting module. Please join us for the other GPLI Keratoconus education.